The next member of the chlamydia genus that we're going to talk about is Chlamydia pneumoniae. There was a brief time where the next two bacteria we're going to talk about were split from the chlamydia genus into their own genus called Chlamydiophila. But it turns out that based on genetics, based on molecular analysis, they do still belong in the same genus. So sometimes you might see written Chlamydiophila, it's chlamydia. Okay, so Chlamydia pneumoniae, formerly Chlamydiophila pneumoniae, causes sinus infection, sore throat, bronchitis, and as you might expect, pneumonia. So this is a respiratory pathogen. It's transmitted by respiratory droplets, and really most patients don't require hospitalization. The bacterium can also be isolated from biopsies of atherosclerotic lesions, but we still don't know if it leads to atherosclerosis or how it could lead to atherosclerosis. So scientists really are not sure if it's just kind of a correlation, we just happen to find them there, or is it a causation that these things actually cause the lesions? The best diagnostic feature for the infection is to look for IgM levels that are specific for the bacterium. And in this case, macrolides are the best antibiotic treatment. The final species we'll talk about is Chlamydia psittaci, again, formerly Chlamydiophila. This is an ornithosis. It's a bacterial infection acquired from, if you've taken ornithology, you know, birds. And psittaci, parrots, usually, or related birds. It infects the respiratory tract. So just like Chlamydia pneumoniae, it is a respiratory pathogen. The bacteria can spread to the liver or spleen, leading to localized necrosis. That's what focal necrosis means, like a focus area of necrosis. It can also spread through the blood to the lungs and other organs, and it can lead to edema, necrosis, hemorrhage, or the formation of mucus plugs that can block the respiratory passages. This is fairly rare in the US. Fewer than 25 cases per year are diagnosed, but it may be underreported due to patients who experience mild infection, which is going to be the majority of patients. Patients who have unknown contact with birds. So if a patient is diagnosed with some sort of respiratory infection and they are often in contact with birds or have recently been in contact with birds, it's a possibility. Serum that's not tested, or cross-reactivity with Chlamydia pneumoniae, so it could be misdiagnosed. This is a 24-year-old man who was admitted to a local hospital in acute respiratory distress. Several days before hospitalization, he developed congestion, muscle pain, cough, slight difficulty breathing, and a headache. Immediately before admission, the cough became productive, so he started having sputum. He developed chest pain, fever, chills, and diarrhea. X-ray demonstrated basically infection in the right upper lobe of the lungs and patchy infiltrates in the left lower lobe. So it's pretty condensed up here in the right upper lobe and sort of patchy in the left lower lobe. Despite the fact that antibiotic treatment included erythromycin, doxycycline, ceftriaxone, and vancomycin, that's a lot of drugs. His pulmonary status did not begin to improve for 7 days, and he was not discharged from the hospital until a month after his admission. A careful history revealed the man had been exposed to parrots in a hotel lobby while vacationing. The diagnosis of Chlamydia psittaci pneumonia was made by growing the organism in cell culture and serological tests. So that's why, as a clinician, it's going to be really important for you to figure out as much as you can. I can almost guarantee that a patient is not going to come into the hospital and be like, "Ooh, I have this respiratory pain, and you know what? I was exposed to parrots about a week ago." No. You, as the clinician, have to understand how these infections are acquired and ask the right questions. Most patients will be honest with you about what they've done, but they don't know to be honest with you if you don't ask the right question. So with Chlamydia psittaci, most patients are going to have uncomplicated infection, 1 to 2 week incubation period, and then the onset of symptoms that the patient might recognize. So they experience a fever, chills, headache. So that'll go for another week or so, and then they'll start to recover. In severe infection, which is going to be mostly in immune-compromised patients, the symptoms get very significant, difficulty breathing, turning blue. It can go and cause jaundice, prolonged recovery, and a 5% mortality. The infection is mostly diagnosed based on serology. It can be cultured in cells, which isn't terribly common, but we saw in the case study that they did do that. Treatment with doxycycline or macrolides, and prevention is really only through the control of infection in birds. And so you can use it's a tetracycline derivative to treat your birds for about 45 days until they clear the infection.